Tell me when you're ready. Okay. Ready for me to start?
Sure.
All right. Well, first of all, thank you for inviting me to speak today. I know I kind of looked through the chat and I recognize many of the names on there. So most of you already at least know me a little bit, but I'm glad to be here. Today, we're going to talk about preeclampsia, and I'll get to the reasons for that in a minute. I have no meaningful conflicts of interest to disclose. No one's paying me, blah, blah, blah. So objectives. So talking about preeclampsia. So, why do we care about preeclampsia? So preeclampsia is something that, if you are in obstetrics or around obstetrics, or you've ever been pregnant, you've heard of preeclampsia. But why do we care about it? It happens frequently, but we care because it is a leading cause of maternal perinatal morbidity, maternal and perinatal morbidity and mortality worldwide. It happens in 2 to 8% of pregnancies worldwide. And in the United States, the rates are actually increasing, probably because of the risk factors that we're going to talk about in a few minutes. And preeclampsia costs billions of dollars annually. And that's mostly attributable to the care of the preterm babies that get delivered because of women with preeclampsia. So with that, the objectives that we're going to talk about, can you go back? I'm sorry, I kind of digressed. My goals today are for you to understand the definition of hypertensive disorders of pregnancy, which include gestational hypertension, preeclampsia without severe features, and preeclampsia with severe features. We're going to review the diagnostic criteria for preeclampsia, which are kind of many and varied. And then we're going to discuss, who's at risk for hypertensive disorders of pregnancy. So the definition of a hypertensive disorder of pregnancy, it includes gestational hypertension, preeclampsia without severe features, preeclampsia with severe features, and something called superimposed preeclampsia. The definition of superimposed preeclampsia is, generally speaking, it's diagnosed in a woman who has pre-existing high blood pressure or hypertension and then develops preeclampsia on top of that. There are other vascular disorders, such as like longstanding diabetes, that and that'll be included in the risk factors in a minute, but preeclampsia can be superimposed on any other vascular disorder, but the technical term is that it's superimposed on chronic hypertension. There's a large, wide spectrum of the disease called preeclampsia. Most of the time, it starts late, it's mild, patients can get all the way to term before they have to be delivered, and there aren't a lot of sequelae for the pregnancy or for the neonate. Occasionally, however, we will see it develop earlier in the pregnancy, even in the second trimester, and it can be very severe. It can have significant concerns for the mom and for the neonate if preterm delivery is required, especially. The definition, again, it's a hypertensive, preeclampsia is a hypertensive disorder of pregnancy. And like I said, there's a spectrum, and it's specifically defined as new onset high blood pressure or hypertension after 20 weeks gestation, in addition to proteinuria. Now, I wrote that that's the classic diagnostic criteria because it doesn't always work that way. Some patients develop preeclampsia and they never get proteinuria. Some patients will complain of headache, and that is one of the the classic parts of the diagnosis, but not all patients get a headache, and a lot of patients get headaches who don't have preeclampsia. Everybody knows somebody who has migraine headaches or just has a lot of tension headaches, and it's very difficult sometimes to tease out. So it's definitely a diagnosis that is kind of ongoing throughout pregnancy in some patients, and it's very clinically oriented. But technically, hypertension plus proteinuria. The pathophysiology of preeclampsia has been debated for years. There are many theories. Several suggested mechanisms have come to light. Imbalance of angiogenic factors is one that's probably more a stronger pathophysiologic possibility. It develops from chronic uteroplacental ischemia, probably because of an imbalance of angiogenic factors. There's some sort of an immune maladaptation in the pregnancy. And there's also more recent literature that suggests that there's definitely a genetic component to the pathophysiology of preeclampsia. I can't tell you how many times I've been in a room discussing a patient's preeclampsia diagnosis, and her mom is sitting there and going, yeah, I had that, and her sister had that. And there's definitely a genetic component to it that we just don't fully understand yet. So the diagnostic criteria for preeclampsia, and again, we're back to technical terms, and it doesn't always work this way, but in general, the diagnostic criteria for preeclampsia are a blood pressure, systolic blood pressure of greater than or equal to 140 millimeters mercury, or a diastolic blood pressure of greater than or equal to 90 millimeters mercury. Doesn't have to be both of them. It just has to be one of those. It needs to have occurred on 2 occasions, at least 4 hours apart. Generally speaking, it needs to happen after 20 weeks gestation. And the patient really can't have a diagnosis of hypertension, which during pregnancy, a lot of women come into the pregnancy saying, no, I don't have high blood pressure, but they come in at 12, 13, 14 weeks, and they clearly have elevated blood pressure. So this would not really apply to them. Proteinuria is the second part of the diagnostic criteria, and that can be concluded by any number of things. The classic diagnosis is 300 milligrams of protein in a 24-hour urine collection. And you can actually, they've discovered that you can do a 12-hour collection and multiply times 2. So there's easier ways to do it. The second and probably more common, more recent way to diagnose proteinuria is with a protein to creatinine ratio, which is a urine sample and not a 24-hour collection. So much, much easier to collect. And then the last method is by urine dipstick, like you would do on a patient when they come in for a prenatal visit. This is suboptimal. There are a lot of false positives, a lot of false negatives. But if you have nothing else, a urine dipstick that has 2+ protein or greater in it can be used for diagnosis, especially if you have other findings. So preeclampsia, I mentioned earlier, can be without or with severe features. So here is the difference in the diagnostic criteria. So severe features include a systolic blood pressure of greater than or equal to 160 as opposed to 140, or diastolic blood pressure at greater than or equal to 110 as opposed to 90. And the same criteria apply of on more than one occasion, greater than 4 hours apart. But if somebody comes in and their blood pressure is, 200 over 120, you're not going to kick back and relax for a couple of hours and then recheck their blood pressure. You're going to do something about it. So the technicality is that it should be greater than 4 hours apart, but nobody's actually going to do that. You're going to take action because those are stroke range blood pressures. Other criteria include thrombocytopenia, generally a platelet count of less than 100,000. Impaired liver function, and you would see that with an elevated AST, ALT, possibly LDH in a more severe form of preeclampsia. You would see renal insufficiency in the form of, again, we've already talked about proteinuria, but also a rising creatinine, pulmonary edema, which is fluid in the lungs, new onset headache, visual disturbances, and seizures. So HELP syndrome, just to kind of talk a little bit more about severe preeclampsia. HELP syndrome is one of the more severe forms of preeclampsia, and it's associated with pretty significant maternal morbidity and can be associated with mortality. So HELP is just an acronym for hemolysis, elevated liver enzymes, and low platelets, like I've put there. Generally speaking, the diagnosis is made if the LDH is greater than 600 international units per liter. The AST and or ALT are greater than or equal to 2 times the upper limit of normal. So just a mildly elevated AST or ALT is not consistent with HELP syndrome, or a platelet count of less than 100,000. This, it can be a little tricky because it can present at any point during pregnancy, usually 3rd trimester, but it actually presents postpartum about 30% of the time. So not only do obstetric providers need to have a low threshold for diagnosing this, but also emergency room personnel, because patients present to any number of places with complaints. And if, one of our driving forces in the Morbidity and Mortality Review Committee is to have the warning signs up of pregnancy complications in all emergency rooms. We want people to be aware because it can present postpartum and people frequently will go to the ER. Again, HELLP syndrome can have a variable presentation. The symptoms that patients come in with can include any of the preeclampsia symptoms I just mentioned, but these patients will usually have right upper quadrant pain and they don't feel good. And the reason for those symptoms, generally speaking, is because of their liver dysfunction. The right upper quadrant pain is caused by the liver, for lack of a better way to put it quickly, is the liver has swelling and there's a capsule around the liver called Glisson's capsule. And when that liver swells, the capsule stretches, and that is just incredibly uncomfortable for patients. And anyone with liver dysfunction, if it's significant, they just have a lot of malaise. They don't feel good. So eclampsia is another severe form of preeclampsia, and it is associated with new onset tonic-clonic focal or multifocal seizures. And of course, this needs to be diagnosed in a patient who does not otherwise have a seizure disorder. But you have to keep in mind that patients with seizure disorders can also get eclampsia. So a little difficult to tease out sometimes. You have to figure out what's going on. This can also present before delivery, during the delivery process, and postpartum. I saw a patient like that just the other day. The symptoms prior to the onset of seizures usually include a severe headache, blurred vision, light sensitivity, and altered mental status. The light sensitivity can kind of make you chalk their symptoms up to a migraine headache, which you don't want to mistake that for eclampsia that's impending. Altered mental status should get your attention when you're talking to a patient like this. So we've talked about maternal effects a lot here. What are the effects on the fetus? So the effects on the fetus are generally associated with uteroplacental insufficiency, or basically lack of blood flow through the placenta to the fetus. And this all has to do with what's called vasospasm. It's one of the things that we always talk about with preeclampsia. There is an inflammatory response to preeclampsia, and one of the parts of response is vasospasm. So effects on the fetus: growth restriction. You can imagine if the placenta is not being well enough perfused with maternal blood, that the baby's not going to grow well. Oligohydramnios, which is low amniotic fluid around the baby. If the mom has, if there's decreased perfusion to the fetus, then the kidneys aren't going to get enough blood flow filtering, and they will make less amniotic fluid. Amniotic fluid being urine from the baby. Placental abruption, which is separation of the placenta from the wall of the uterus, from vasospasm again. And then you can just have a non-reassuring fetal heart rate tracing when the woman comes into triage or labor and delivery. Another effect on the fetus, which is usually because we say she needs to be delivered for curative effect, is the preterm delivery, the prematurity, and the NICU admissions, and all of the things that are complicated with that. And then occasionally we will see a woman come in with a fetal demise, and the diagnostic or what we end up diagnosing in her is preeclampsia, which is unfortunate. So the differential diagnosis for preeclampsia, most of the time you're going to consider these things when a patient has signs and symptoms of preeclampsia in the period before 20 weeks gestation. And you're really going to be looking at this with patients who are showing you symptom signs of HELLP syndrome. And so this isn't like AFLP stands for acute fatty liver of pregnancy. That is associated with significant liver function impairment. And so when somebody comes in and their liver function is not correct and they don't feel well, you have to throw these things into the differential diagnosis. And also, if a patient has new onset hypertension and symptoms and signs of preeclampsia before 20 weeks, you sort of have to question your diagnosis. So that's whereby this differential comes. Acute fatty liver of pregnancy, TTP stands for thrombotic thrombocytopenic purpura, immune thrombocytopenic purpura, hemolytic uremic syndrome, catastrophic antiphospholipid syndrome, and lupus, a flare of lupus. And the one thing I left off this slide is a potential molar pregnancy. And also all of these things need to be in the differential because they are all associated with, at least in part, low platelets, liver dysfunction, renal dysfunction, and adverse fetal effects. So that's why that differential is there. The other differential diagnosis could be just chronic hypertension. If you have a patient that shows up after 20 weeks for their first prenatal visit and their blood pressure is severe, that's actually one of the more common things. We usually admit those patients and have to decide, does she have preeclampsia or does she just have high blood pressure? And she didn't know about it because she doesn't, get care or check her blood pressure when she's not pregnant. So a question that comes up frequently is how can we screen women for preeclampsia? How do we, is there a way for us to predict who's going to get preeclampsia? Unfortunately, there have been many things proposed: biochemical and biophysical markers, blood tests, Doppler studies and this is particularly of the mom, uterine artery Dopplers are something that, honestly, I'll still do them because they do help us predict uteroplacental insufficiency, but they're not as good at predicting preeclampsia. Angiogenic factors, all of these, especially in a low risk population, they're just not reliable, and then they should be considered experimental. Having said that, if I have a woman who has a severely growth restricted fetus in the mid-second trimester, I will frequently ask the sonographer to get uterine artery Dopplers to help me figure out, is this because the placenta is not working okay or the mom's blood flow is not what it should be? Anyway, much research has been done on this and is being done moving forward. But at this point, we do not have a standalone screening test for preeclampsia. And a screening test, one of the hallmarks of a good screening test is that there's an intervention that's reasonable and acceptable to the patients that are getting it. And you screen somebody for preeclampsia at 15 weeks gestation. What are you going to do about it? There's one preventive, but it's not. We'll talk about that in a little bit. Anyway, so what are the risk factors for preeclampsia? And this actually goes back to a couple of things that we talked about earlier about the rate of preeclampsia increasing over the years. So risk factors include, and there's a lot of them, nulliparity, just first pregnancy, multiple gestations. Somebody who has a history of preeclampsia in a previous pregnancy is definitely at risk to get it again. Patients with chronic hypertension, pre-gestational diabetes or gestational diabetes, any woman with a thrombophilia, which is a clotting disorder, women with lupus are at increased risk for preeclampsia, obesity, antiphospholipid syndrome diagnosis, advanced maternal age, and actually what that really should say is extremes of maternal age. So a 41-year-old is at risk, but also a 14-year-old is at risk. And so think about that as extremes of maternal age and not really just advanced maternal age. Women with underlying renal disease, women who have assisted reproductive technology to get pregnant are at increased risk for this, and then women with sleep apnea. Now, a few minutes ago, I said that the rate of preeclampsia is increasing and specifically in the United States. And when you think about these risk factors, the rates of obesity are going up, and the rates of women who are having children at an older age are going up. The rates of IVF are going up because women are getting pregnant at an older age, and they're more likely, if they have IVF, they're more likely to have a multiple gestation. So I just hit on, I think, 4 of those risk factors that are all increasing as the years go by. And there you go. If you're wondering why is the risk or the rate of preeclampsia increasing. The best screening test, or the best risk factor screening for preeclampsia truly is just looking at those risk factors. You can screen for women who are at risk for preeclampsia just looking at those risk factors. So how do we manage preeclampsia? Well, that kind of depends on what you're looking at. If a woman has preeclampsia without any of those severe features, they feel fine, they look fine, otherwise they are fine, you can actually manage these women outside of the hospital. There are some caveats to that. They have to be willing to come in frequently for evaluations because preeclampsia without severe features can turn into preeclampsia with severe features fairly quickly. We would expect the patient to come in for serial labs so that we can check their liver function, kidney function, platelet count. We would expect them to come for twice weekly, what we do at our institution, antenatal testing. And by antenatal testing, I mean fetal assessment. Put them either do an ultrasound for a biophysical profile or put them on the monitor to monitor the baby's heart rate. And the reason for that is just, a woman who's women with preeclampsia are at increased risk for fetal demise. We would, again, like I said, frequent visits. Any woman with preeclampsia should be delivered by 37 weeks gestation and absolutely no later. It helps if the patient has a blood pressure cuff at home and they can trend their blood pressures for you, because 2 blood pressures a week doesn't really cut it. But they have to be able to check their blood pressure at home in a reliable fashion. And then again, just a reliable patient. If somebody's not coming for prenatal care, it kind of makes you concerned that they might not come in for their twice weekly testing, which puts them at increased risk for complications. So a patient that has severe features, and this includes, I didn't go into gestational hypertension too much here, but gestational hypertension is basically hypertension without proteinuria and no other severe features. So when I say severe features, I'm talking about gestational hypertension with severe features or preeclampsia with severe features. They're basically one and the same, and we treat them the same. So severe features, if a patient has only got severe blood pressures to diagnose them with severe preeclampsia or preeclampsia with severe features, you can manage them expectantly. All of these women need to be managed in the hospital. None of these people need to be managed outpatient, because this really can get worse very quickly. With severe blood pressures only, you want to give them a course of betamethasone and watch them very closely in the hospital with frequent blood pressure checks, lab draws, symptom checks, and fetal monitoring. You can treat their blood pressures with antihypertensives. And the recommendation for these women is always delivery by 34 weeks gestation. This needs to be a shared decision-making process with the patient. So I've had some patients that are like, what, I'm really not comfortable sitting on this. I think I would much rather be delivered and then let the, chips fall where they may. I'm not comfortable with this from my standpoint or the baby's standpoint. And at that point, you engage the NICU physicians and you have them come and engage with the patient and give them patient education about the risks of, preterm delivery. And it's a risk benefit ratio all the time. But as long as everybody's on board with the plan, you can manage these patients conservatively. If a patient has any other severe features, again, inpatient, you give them betamethasone. If possible, you complete a course of betamethasone, but sometimes you can't, and then you deliver the baby, and it doesn't matter what the gestational age is. So there are contraindications to expectant management. Contraindications from the mom standpoint, like I just mentioned, if their blood pressure is uncontrolled, even with antihypertensives, you just have to deliver the baby. That's all there is to it. And of course, the key really is delivery of the placenta. You can increase their PO medications, but if I'm not comfortable increasing blood pressure medications to the point that I really have, if I've maxed out 2 medications, we're finished and we're going to proceed with delivery. A patient with neurologic symptoms that make you think she might be about to be eclamptic, such as unrelenting headache, any unrelenting epigastric or right upper quadrant pain, anything that goes along with the headache, like visual disturbances or motor deficits or altered sensorium, those women just need to be delivered. Any woman who comes in and has had a stroke, cardiac arrest, or myocardial infarction, a woman with HELLP syndrome, worsening renal function, all of these reasons are indications for just really pretty much immediate delivery. Stabilize, at least start steroids, give magnesium sulfate, and we'll talk about that in a minute, and then deliver. Fetal contraindications include a non-reassuring fetal heart rate tracing or abnormal Dopplers, any non-reassuring fetal status, basically. If the baby is not alive, there's the point of conservative management or expectant management is for fetal benefit. So if there is no benefit to the fetus, you just have to deliver. Intrapartum management, I know I'm about out of time here. Seizure prophylaxis with magnesium sulfate. There's no consensus about this in patients without severe features, and you have to adjust the dose if the mom's kidney function is impaired. you want to give them antihypertensives, and you can actually start long-acting medications. And then the mode of delivery is really based on what else is going on in her gestational age. Postpartum, really important. Preeclampsia can present in the postpartum period for the first time in the whole pregnancy. So it is incredibly important for healthcare providers to have increased suspicion for preeclampsia in any woman who presents postpartum with any of these symptoms. Emergency rooms need to be aware, urgent cares, primary care, and obviously obstetrics providers. We give magnesium sulfate for 24 hours for patients with severe features of preeclampsia, and that's for seizure prophylaxis and routine postpartum care and blood pressure medications. And then we educate them about the risk for preeclampsia in future pregnancies. Low-dose aspirin is actually known to prevent preeclampsia if started before 28 weeks and ideally before 16 weeks. There's a distinct reduction in early onset severe preeclampsia in the next pregnancy. And there are no known adverse neonatal outcomes from using low-dose aspirin. I went over my time, I'm sorry. You could talk